This recorded lecture will be going over Chapter 30, Promoting Bowel Elimination in the Fundamentals textbook. These next few slides will be a review over our structure and function portion of the program. Bowel elimination, which is the excretion of solid waste, is our final step in the process of digestion. When an alternative for waste elimination is needed due to disease of the intestine and ostomy can be performed. We know that the small intestine consists of the duodenum, the jejunum, and the ileum, carries chyme from the stomach to the large intestine. The small intestine attaches to the large intestine at the cecum. The large intestine has four main sections: the ascending colon, transverse colon, descending colon, and sigmoid colon. The large intestine is larger in diameter than the smaller intestine. The distal portion of the large intestine is the rectum, which connects to the anus, which is the opening of the rectum at the skin. And this picture can be seen on page 583, figure 30.1, the intestinal system. The walls of the intestines have four layers: the mucosa, submucosa, muscular layer, and a serous layer, called the serosa. The small intestine will further process chyme into a more liquid state. In the large intestine, water, sodium, and chlorides are reabsorbed, and waste material is propelled to the anus. The large intestine contains bacteria that breaks down waste products. Peristaltis is the wave-like movement throughout the intestines. This moves chyme and gas formed by bacterial action through the intestines. The movement of liquid and gas causes the rumbling noise of bowel sounds. It takes about 18 to 72 hours for food to move from the mouth to the anus. Feces is our intestinal waste material. It is stored in the sigmoid colon until it moves into the rectum for expulsion through the anus. As the rectum fills, the pressure on the sphincter of the anus increases until the urge to defecate will occur. Our abdominal muscles will contract and help force the evacuation of the rectum. Our internal anal sphincter, which is located at the top of the anal canal, is under involuntary control. Our external anal sphincter at the end of the anal canal is under voluntary control. Our gastrocolic reflex will initiate peristaltis, which in turn initiates the urge to defecate. This is stimulated by eating. Intra-abdominal pressure can increase when a person holds their breath, closes the glottis, and tightens their abdominal muscles. This will initiate voluntary defecation and is known as a Valsalva maneuver. Atrophy is a decrease in size that occurs in the villi of the small intestine. This can decrease the total absorptive surface area. Sometimes twisting of blood vessels supplying the large intestine will compromise the blood flow to the large intestine. Motility in the large intestine can decrease in some individuals, but bowel habits should not change with the aging, healthy individual. Stool is another term for feces. The appearance of stool is influenced by diet and metabolism. Normal stool should be light to brown, light to dark brown, soft, and formed. The light to dark brown color is caused by bile. The color of feces can be changed by certain vitamins, drugs, or diet. The most serious abnormality is blood in the stool. Occult or hidden or old blood is suspected when the stool changes from a normal brown appearance to a dark black color with a sticky appearance. The observance of blood in the stool needs to be reported promptly and documented in the patient's medical record. Conditions that would cause blood in the stool include hemorrhage from ulcers in the stomach or duodenum, severe inflammation or irritation, as in ulcerative colitis or diverticulitis, and cancer. Bright red blood mixed in the stool is a sign of recent GI bleeding that has occurred in the large intestine. Eating red foods like beets can make the stool appear red, so dietary assessment is essential. Pale white or light gray stool would indicate an absence of bile in the intestine. Other abnormal characteristics of feces are the presence of large amounts of mucus, fat, purulent matter, or parasites such as worms. Stools with an abnormally high fat content or steatorrhea are usually very foul-smelling and will float on the water. They also normally appear frothy. The first signs of colorectal cancer are changes in bowel patterns and stool characteristics. Evidence-based practice indicates that beginning at age 50, a colonoscopy should be done every 10 years. An absence or reduction of peristaltic movement of the bowel will result in a hypoactive bowel. In addition, after abdominal surgery, patients can develop a paralytic ileus. This is when peristalsis stops due to the manipulation of the bowels during surgery. Encourage an increase in fiber sources, such as fruit, vegetables, and whole grains, in accordance with the Healthy People 2030 objectives. Constipation is the most common problem of a hypoactive bowel. Constipation can occur when muscle tone is lacking, when bowel movements are irregular, or when excessive worry, anxiety, or fear is present. Nurses need to be aware of any potential illness-induced constipation. Any patient restricted to bed rest is at risk for constipation. Many medications, barium X-ray studies, or recovery from surgery can contribute to constipation. Patients at risk for constipation should be identified early. Abdominal distension can be caused by flatus or gas that accumulates in the intestinal tract when peristalsis is reduced or absent. Just as fecal matter can collect in the hypoactive bowel, so can flatus. Distension and gas pains will occur frequently after an abdominal surgery. On page 585 in box 30.1, we can see some medications that may cause or contribute to constipation. This would include narcotic analgesics, general anesthetics, diuretics, sedatives, antidepressants, anticholinergics, and calcium channel blockers. Also be sure to check out the diagram, the concept map on page 585 for constipation, and you can see how a hypoactive bowel and the factors that contribute to that, and hardened stool as well as the factors that contribute to that, will all lead to constipation. Studying that concept map can be very helpful to understanding how these factors all work together to cause these very irritating situations. On page 586 in box 30.2, we can see some common medications used for constipation or diarrhea. It would be important to pay attention to the medications used for diarrhea, like antidiarrheals, such as loperamide or Imodium. We also have stool softeners, such as docusate sodium, also known as Colace. We have bulk-forming laxatives, psyllium, this is going to be like your Metamucil. Irritant or stimulant laxatives, we have Biscotal, this is your Dulcolax, Senna. Saline laxatives, such as your Magcitrate, and laxatives for chronic constipation. Increased motility of the GI tract or increased peristaltis will result in a hyperactive bowel. Sometimes this can also result in diarrhea. This can occur when increased peristaltis pushes food through the intestinal tract too quickly. Often diarrhea is simply the body trying to rid itself of pathogens or toxins from spoiled food. Moderate diarrhea lasting a couple of days will usually resolve by itself. At times, diarrhea can lead to temporary fecal incontinence, which is the inability to have control over your voluntary sphincter, an inability to retain your feces. On page 586 in the lifespan considerations box, the green box, see the older adult. Older adults become dehydrated more quickly than younger adults. Observe them closely for any signs of dehydration and fluid imbalance when diarrhea occurs. Commercial beverages such as Gatorade that contain sodium and potassium, taken in small amounts at a time, can help replace electrolytes if a patient has continuing diarrhea. Evidence-based practice indicates the consumption of caffeinated tea, coffee, or soft drinks will further contribute to the dehydration. If the person becomes confused and dehydrated, a trip to the emergency department for fluid replacement will be necessary. People of all ages can become incontinent of feces due to illness such as stroke, traumatic injury, or any neurologic dysfunction. Every patient is assessed regarding bowel status every day in an inpatient facility. The patient should be questioned about the regularity of their bowel evacuation, any problems, and any abnormal characteristics in their stool. Many people think that it's abnormal not to have a bowel movement every day, but having a bowel movement every 2 to 3 days can be very normal for some people. Distension can be revealed by an abdomen that is rounder and tighter in appearance than normal. The patient's abdomen should be assessed for distension by percussion and the nurse gently palpating on the 4 quadrants of the abdomen to check for any tenderness and masses. A normal abdomen will be non-distended, soft, and have active bowel sounds in all 4 quadrants. See the clinical cues on page 587 in the purple box. Place the patient in a supine position. Auscultate for bowel sounds in all 4 quadrants. Absent or few bowel sounds will indicate decreased motility and potential for constipation, or may signal an abnormal bowel blockage. Active bowel sounds are associated with the increased motility that occurs after eating. Loud hyperactive sounds, called borogemy, can occur with diarrhea. Percussion should be used to detect abnormal amounts of gas, and areas of gas will produce a drum-like hollow tone. Also see on page 587 the focused assessment in the purple box. Under physical assessment, it's important to observe the shape of the abdomen with the patient supine. Auscultate for bowel sounds in all 4 quadrants. Percuss for the presence of excessive air or gas in the bowel, and then gently palpate for masses or tenderness in all 4 quadrants. It's important when planning to understand that ordered treatments such as enemas will take extra time and to plan accordingly for such. You must assist the patient on bed rest with the use of the bedpan or bedside commode. Privacy is very important. Patients should be assisted into as much of a sitting position as their condition will allow. Check to see that the patient is thoroughly cleaned, especially if the patient cannot lift up off the pan to clean the anus and surrounding area. The bedside commode should always be emptied and cleaned promptly after use. When the average patient has not experienced a bowel evacuation within 3 days, you should take measures to assist with their elimination. The least invasive measures will be used first. This includes encouraging and monitoring activity, adequate fluid intake, and a diet with sufficient fiber can help lead to regular bowel elimination. Non-invasive measures that can be used to promote bowel elimination include the consumption of 1 to 3 tablespoons of bran mixed with apple juice, small amounts of prune juice, warm prune juice and cola, hot water with lemon juice, or stewed or dried prunes. If these actions aren't successful, implement more invasive measures to promote bowel elimination. These measures would include administration of medications to soften the stool, suppositories to stimulate the urge to defecate, laxatives to stimulate bowel activity, and enemas to empty the rectum. All of these measures would require a doctor's order for a hospitalized patient. Measures to rid the bowel of barium are essential after a patient has had a barium X-ray examination. Encourage an increase of fluid intake of 3,500 mL per day over 24 hours unless contraindicated. A laxative will often be recommended. Encourage home care patients to telephone the nurse if they haven't had a bowel movement in 3 days. Impaction can be prevented if constipation is treated early. When a patient experiences incontinence, cleansing should occur as soon as possible. Skin can become excoriated due to the feces irritating it. A patient who is having diarrheal stools may need a skin protectant around their anus to prevent any skin breakdown. Gentle washing with soap and water, rinsing, and patting dry are essential. When diarrhea is thought to be caused by bacteria or a virus, the primary care provider may want to let it run its course for at least 24 hours, just so the body has a chance of ridding itself of that offending organism. Treatment would involve placing the patient on a clear liquid diet to rest the bowel, replacing fluids and electrolytes, and then seeking medication to stop the loose stools. Observe for any signs of dehydration when the patient has severe diarrhea. Decreased skin turgor, dry mucous membranes with thick saliva, and increased thirst. Self-medication for diarrhea should not continue for more than 48 hours without consulting a primary care provider. Document any changes in bowel habits, stool characteristics, episodes of constipation or diarrhea, and any measures that are taken to remedy the problem. All measures to promote bowel elimination need to be documented. Rectal suppositories are used to promote bowel movements. Suppositories that promote bowel evacuation will do so by stimulating the inner surface of the rectum and increasing the urge to defecate, forming gas that expands the rectum, or melting into a lubricating material to coat the stool for easier passage through the anal sphincter. An enema is the introduction of fluid into the rectum and the colon by means of a tube. An enema kit will contain a bag or a bucket for the solution. Enemas can be given at any time, but it's best to try to give them before the morning bath and bed linen change. The type of enema to be given will be prescribed by the primary care doctor, and it'll vary depending on the patient's age and their condition, the purpose of the enema, and the doctor's preference. On page 590 in table 30.1, you can see types of enemas and their actions. Note that the cleansing enema would consist of soap suds, like 5 ml of castile soap and 1,000 ml of water, tap water, and saline. For a saline enema, you would want to use 500 to 1,000 ml of normal saline. It is important for nurses to know these amounts. Often an oil retention enema can be ordered for a patient with constipation. The oil needs to be retained in the rectum to soften and coat the hardened feces, and the oil should be retained for at least 20 minutes if the patient is able to. You can see this picture on page 591 in figure 30.4. This would be the position to give an enema. Disposable enema units will contain about 240 ml of solution. They can be given at room temperature, but they work best when the solution is slightly warmed. See the cues and considerations for safety on page 591. The temperature of the enema solution should be about 105 degrees Fahrenheit. If a bath thermometer is not available, test the temperature of the fluid by pouring a small amount over the inner wrist. It should be warm to the touch, but not hot. Solution that is too cool usually cannot be retained, and hot solutions can damage the tissues of the rectum. Hold the container approximately 12 to 18 inches above the patient's anus and allow the warm solution to run in slowly. A greater height will create too much pressure because the fluid will run in too rapidly and then cause painful distension of the rectum and colon. Also see the cues and considerations for safety on page 591. When in order to give enemas until clear is written, it means that the returned fluid must not have any fecal matter in it. However, no more than 3 large volume enemas should be given without checking with the primary care provider. Repeated enemas can deplete electrolytes, and this can be very dangerous for your patient. The position of choice when giving an enema is the left Sims position, with the hips slightly elevated. When a patient is uncomfortable due to flatulence in the lower bowel, a rectal tube can be inserted into the anus. Fecal impaction means that the rectum and sigmoid colon have become filled with hardened fecal material. The most obvious sign of fecal impaction is the absence, or only a small amount of, bowel movements for more than 3 days in a patient who normally has bowel movements more frequently than that. The very young and the very old are more prone to fecal impaction. Our nursing responsibility would include prevention of the fecal impaction through daily assessment of bowel patterns for all of our patients. Digital removal of a fecal impaction must be done gently, and the patient needs to be watched for any signs of a vagal response due to stimulation of the sphincter and rectal wall. The vagal response can cause a slowed pulse and cardiac arrhythmias, and an alteration in blood pressure can develop. Should this occur, you need to immediately stop the procedure, place the patient in a supine position, and monitor their vital signs very closely. Of course, notify the primary care provider. A dose of atropine can be ordered to counteract a vagal response. The treatment for incontinence is training for bowel control. This is a long process, but it will help the patient regain their self-esteem. Patients who require bowel training need to be physically disabled or confused in order to participate. A bowel training program is based on the principles for establishing regular bowel elimination. This includes adequate diet, sufficient fluids, adequate exercise, and sufficient rest. A regular time for evacuation should be established. A reasonable goal would be to achieve defecation within 1 hour of the established time. Factors that help establish the time will include the patient's prior bowel habits or the nurse's observation of when incontinent movements will tend to occur. Many bowel retraining programs are timed around triggering a meal when the gastrocolic reflexes are the strongest, most commonly after breakfast. Privacy and adequate time are only 2 parts of the environment that are considered. Be sure to provide the patient with toilet tissue and remember to encourage hand hygiene after the evacuation. Suppositories such as stool softeners and bulk laxatives can be used to establish a normal, regular bowel pattern. To avoid any intestinal obstruction, bulk-forming laxatives must be taken with a sufficient amount of fluid, and they should generally not be taken at bedtime. In most cases, stronger laxatives and enemas are not considered a part of a bowel training program. Disease or trauma can damage the intestinal system and require surgical intervention. This will alter the process of elimination. A diversion of intestinal contents from the normal path is called an ostomy. An ostomy will result in the formation of an external stoma. This is the opening of the intestinal or internal tissue pouch with a valve nipple opening. The internal pouch forming the consonant ostomy is usually constructed from a segment of bowel. Human elimination is a subject that many adults will view with embarrassment or distaste. Focus on keeping your body language neutral and not displaying any sign of distaste, even unconsciously, whenever caring for an ostomy patient. An attitude of acceptance is very important. Conditions that can require ostomies include cancer, abdominal trauma, congenital bowel malformation, and severe chronic Crohn's disease or ulcerative colitis. The patient needs a support system in place before they can be discharged from the hospital. An ileostomy is an opening surgically created at the ileum to divert intestinal contents. This would be performed because lower portions of the bowel have been surgically removed. Effluent or discharged fecal matter from an ileostomy is liquid. A colostomy is an opening into the colon. The stoma is the entrance to the opening. Patient care would include providing the skin care around the stoma and applying appliance, or, if there is a continent ileostomy, draining it with a catheter. These pictures can be seen on page 597, and they're showing you where the ostomy and stoma would be in different parts of the colon and the ileum. Periostomal is around the stoma. This type of care includes assessment of the health of the stoma and then the skin surrounding it. The stoma should appear pink or red. This would indicate adequate blood supply. Always assess the skin around the stoma for any signs of irritation or breakdown. Apply a skin barrier paste with care to prevent any of it from getting on the stoma. Ostomy appliances will come in many different sizes and types. It's essential that the appliance be the correct size for the patient's stoma. The stoma must be measured so that the correct size appliance can be chosen. Pouches should be emptied and rinsed as needed and need to be detached and replaced only every few days. It's best to try to empty stool from the pouch when it becomes 1/3 to 1/2 full so that the weight of effluent does not pull the appliance loose.